Neurocognitive disorders represent a broad category of conditions that significantly impact cognitive functioning, affecting millions of individuals worldwide and presenting substantial challenges for patients, families, and healthcare systems. These disorders encompass a spectrum of conditions ranging from mild cognitive impairment to severe dementia, with delirium serving as a particularly acute and potentially reversible form of cognitive dysfunction. Understanding the complex relationship between neurocognitive disorders and delirium requires examining their underlying mechanisms, clinical presentations, risk factors, and management strategies. The human brain, with its intricate network of neurons and synapses, relies on precise coordination of multiple cognitive domains including attention, memory, executive function, language, and visuospatial abilities. When these systems become disrupted through various pathological processes, neurocognitive disorders emerge. The Diagnostic and Statistical Manual of Mental Disorders, 5th edition, classifies these conditions into major and mild neurocognitive disorders, distinguishing them based on the severity of cognitive decline and functional impairment. Major neurocognitive disorders, previously known as dementia, involve significant cognitive decline that interferes with independence in everyday activities, while mild neurocognitive disorders represent noticeable but less severe changes that do not substantially impact daily functioning. Delirium stands apart from other neurocognitive disorders as an acute, fluctuating disturbance in attention and awareness that develops rapidly, typically over hours to days. This condition represents a medical emergency requiring immediate intervention, as it often indicates serious underlying medical conditions and can lead to prolonged hospitalization, increased mortality, and long-term cognitive impairment. The pathophysiology of delirium involves complex interactions between neurotransmitter systems, inflammatory processes, and metabolic disturbances that disrupt normal brain function. Unlike the gradual progression typical of many neurocognitive disorders, delirium presents with rapid onset and characteristic fluctuations in consciousness and cognitive abilities throughout the day. The clinical presentation of delirium varies significantly among patients, encompassing hyperactive, hypoactive, and mixed subtypes. Hyperactive delirium manifests with agitation, restlessness, hallucinations, and disorganized thinking, making it more readily recognizable to healthcare providers. Conversely, hypoactive delirium presents with lethargy, reduced motor activity, and withdrawn behavior, often being misdiagnosed as depression or dismissed as normal aging. Mixed delirium combines features of both subtypes, creating additional diagnostic complexity. The fluctuating nature of delirium symptoms, with periods of relative clarity alternating with confusion and disorientation, distinguishes it from other neurocognitive disorders that typically follow more predictable patterns of progression. Risk factors for developing delirium are multifactorial, including both predisposing vulnerabilities and precipitating factors. Advanced age represents the most significant risk factor, with older adults being particularly susceptible due to age-related changes in brain structure and function, reduced physiological reserves, and increased prevalence of comorbid conditions. Pre-existing cognitive impairment, whether from mild cognitive impairment or established dementia, substantially increases delirium risk, creating a complex interplay between chronic and acute neurocognitive disorders. Other predisposing factors include sensory impairments, depression, malnutrition, and functional disabilities that compromise an individual's ability to cope with stressors. Precipitating factors for delirium encompass a wide range of medical conditions and interventions. Infections, particularly urinary tract infections and pneumonia, commonly trigger delirium in vulnerable individuals. Metabolic disturbances such as electrolyte imbalances, hypoglycemia, and organ dysfunction can rapidly alter brain function and precipitate acute cognitive changes. Medications represent another significant precipitating factor, with anticholinergic drugs, benzodiazepines, opioids, and polypharmacy increasing delirium risk. Surgical procedures, particularly cardiac and orthopedic surgeries, create substantial physiological stress that can overwhelm compromised cognitive reserves. Environmental factors including sleep deprivation, immobilization, and unfamiliar surroundings contribute to delirium development, particularly in hospitalized patients. The relationship between delirium and other neurocognitive disorders is bidirectional and complex. Individuals with existing cognitive impairment face heightened delirium risk, while episodes of delirium may accelerate cognitive decline or unmask underlying neurodegenerative processes. Research suggests that delirium may serve as a catalyst for the development of persistent cognitive impairment, particularly in previously unimpaired individuals. The inflammatory processes associated with delirium may contribute to neuronal damage and accelerate the pathological changes characteristic of Alzheimer's disease and other neurodegenerative conditions. Prevention strategies for delirium focus on identifying high-risk individuals and implementing multi-component interventions targeting modifiable risk factors. The Hospital ElderLife program and similar initiatives emphasize the importance of maintaining cognitive stimulation, ensuring adequate hydration and nutrition, promoting sleep hygiene, encouraging early mobilization, and optimizing sensory function through appropriate use of glasses and hearing aids. Medication reconciliation and careful monitoring of drug interactions help minimize pharmacological precipitants of delirium. Environmental modifications, including orientation aids, familiar objects, and consistent caregivers, can help reduce confusion and anxiety in vulnerable patients. Early recognition and prompt treatment of delirium are essential for optimal outcomes. Healthcare providers must maintain high clinical suspicion for delirium in at-risk populations and utilize validated screening tools, such as the Confusion Assessment Method or the Richmond Agitation Sedation Scale. The diagnostic process requires careful differentiation from other neurocognitive disorders, psychiatric conditions, and normal aging processes. Comprehensive medical evaluation should identify and address underlying precipitating factors while ensuring patient safety through appropriate monitoring and supportive care. Management of delirium requires a multidisciplinary approach addressing both the underlying causes and the behavioral manifestations of the condition. Treatment of precipitating factors takes priority, including antimicrobial therapy for infections, correction of metabolic abnormalities, and optimization of pain management. Non-pharmacological interventions form the cornerstone of delirium management, emphasizing reorientation, family presence, consistent caregiving, and environmental modifications to promote comfort and safety. When pharmacological intervention becomes necessary for severe agitation or psychotic symptoms, low-dose antipsychotic medications may be considered while carefully weighing benefits against potential risks. The prognosis for individuals experiencing delirium varies considerably depending on multiple factors including age, underlying health status, severity of precipitating illness, and timeliness of intervention. While delirium is potentially reversible, complete recovery is not universal, and many patients experience prolonged cognitive impairment or accelerated decline. The condition significantly impacts healthcare utilization, with increased length of hospital stays, higher rates of institutional placement, and elevated mortality rates. Long-term consequences may include persistent cognitive deficits, functional decline, and increased risk of developing dementia. The economic burden of delirium extends beyond immediate healthcare costs to include long-term care needs, lost productivity, and caregiver burden. Healthcare systems increasingly recognize the importance of delirium prevention and management programs as cost-effective strategies for improving patient outcomes and reducing resource utilization. Quality improvement initiatives focusing on delirium prevention have demonstrated significant reductions in incidence rates and associated complications. Future research directions in neurocognitive disorders and delirium include investigation of biomarkers for early detection, development of targeted therapeutic interventions, and exploration of the relationship between acute and chronic cognitive impairment. Advances in neuroimaging, genetic testing, and biomarker discovery may enhance our understanding of the underlying mechanisms and improve diagnostic accuracy. The integration of artificial intelligence and machine learning technologies holds promise for developing predictive models and personalized treatment approaches for individuals at risk of delirium and other neurocognitive disorders. In conclusion, neurocognitive disorders and delirium represent significant challenges requiring comprehensive understanding, early recognition, and evidence-based management strategies. The complex interplay between acute and chronic cognitive impairment underscores the importance of integrated care approaches that address both immediate needs and long-term outcomes. Through continued research, education, and implementation of best practices, healthcare providers can improve outcomes for individuals affected by these challenging conditions while reducing the broader societal impact of cognitive impairment.